afternoon, everybody. My name is Mike Clegg. I'm Dean of the school, and I want to welcome everybody here this afternoon for the Dean's Lecture. And I think everybody knows who's here that we're celebrating the promotion of Abdullah Baqui to professor in the school. And it is an incredible accomplishment to be promoted to professor at any academic institution, but here it's especially rigorous. And so we're here to enjoy the day and celebrate it with you. And just want to tell you, I'm sure everybody in this room is a friend of Abdullah's and knows him very well, but I'll just talk a little bit about his career. He went to medical school in Dhaka in Bangladesh and graduated in 1976. And his plan was to become an internist, which is a very good thing to do in life. But he was hired by a young CDC officer to work in what then later became the International Center for Diarrheal Disease Research. And that CDC officer was Bob Black. And as Abdullah has told me, that hire changed his life. He went from thinking about a career in clinical medicine to becoming a public health physician. And he eventually came to our school, and we were students at the same time, did an MPH, then did a DrPH, and he went back to Bangladesh where he worked at ICDDRB and accomplished great things. And then, when I was about 2000, I was having a midlife crisis, and I bought a truck. But what he did is he came back to the school and changed careers and became a full-time academic. And over the last 10 years has just built an incredible body of work that has helped improve the health of children and women all over the world. He has active projects in Bangladesh, as you would expect, but also throughout the world in Ethiopia, Tanzania, and other places. And I sometimes say, and it's true for you, that the way the process works is to get promoted. The chair prepares a letter, and then we ask people around the world to weigh in on whether this candidate merits promotion in our school. And those letters are confidential. They come back, the referee letters. But that's what the judgment is made on. And I wish that you could read the letters that people wrote about you. But they all said the same thing. An incredibly great person who's made wonderful contributions to science and to public health, and a broad range of them, and that how fortunate we are to have you at our school. So Abdullah, I won't say any more except to say congratulations, and we look forward to your talk.
Good afternoon. Thank you, Dean Clegg, for your kind remarks and generous introduction. My talk this afternoon will be a reflection of my work. I think Dr. Clegg mentioned that I came to the school in 2000, kind of in mid-career. And so it will be a reflection of my work in the last 10 years, but focus on research. And then also I'll try to talk about what I see as opportunities for future research that can be built on the work I've done to date. For the last 10 years, my research focus was on developing and trying to help deliver evidence-informed intervention around newborn health. So it's more like community-based newborn care and how you can develop intervention that can be delivered at the community level to improve newborn survival. Most of the work was done in South Asia and Sub-Saharan Africa. And so development, design, development, and delivery of evidence-informed intervention involves a number of steps. So I tried to summarize them in a simple framework, but things are not really that simple. In my mind, I think the first step is to define the problem, which involves assessment to estimate the burden of the problem, and also to define who is affected, where, and why. The next step is the design and test intervention. And it's important to understand that the descriptive epidemiology is just one input in the design of that intervention. There are many other inputs. Context is very important. It's very important to understand the context where the intervention will be implemented. It's also important to assess how feasible is that intervention to implement. And of course, we design intervention to assess or test for effectiveness or efficacy, and also it's important to estimate cost. So we generate evidence to influence policy and program. We just don't do research for research sake. The purpose is to generate evidence that can be used to influence program and policy. And but I think evidence is just one piece that influence policy. There are many other things, like including politics. When we try to implement intervention at a programmatic scale, often it requires adjustments. Also, initial implementation, in fact, not initial, all implementation should have built-in monitoring and evaluation so that there is ongoing learning that can help us to develop a program that is effective. The ultimate goal is, of course, to deliver any intervention at a scale and using health systems or approaches that can be evaluation, operational research. There are many different ways of assisting larger scale implementation. But also larger scale implementation requires commitment from both policy and politics. You need both support and investment, larger scale investment to improve the health systems. My work, in fact, encompasses all of this. That may seem a little too much, but I try to develop intervention, test intervention, and then also work with programs and help them to implement those programs in an effective manner. The middle panel of that framework shows the typical time lag. I think maybe those may be underestimates, how much time it takes from design to development to delivery. And one of my goals is to try to reduce that time lag by forming partnership with program and policy. So what we do is really work with program and policy colleagues from the beginning of our research. We engage them in initial assessment. We engage them in formulation of research question, in implementation, in evaluations, and with the goal in mind that will help enhance local ownership of research results, and hopefully that will help increase the chance of adopting the research results in a real setting. Okay, so my talk will have, I have a 4-part talk. First, I'll talk about the background of the newborn health problem. There can be a question, why research on newborn health? So I'll try to address that question. And then talk about the goals, activities, and guiding principles of my work. And then I'll talk about design and finding of selected research projects. I think because my work involves a wide area of activities, I thought that it's not possible to talk about everything. Best is to talk about a selection of work that can illustrate the kind of work I do. And then in the last end of my presentation, I'll try to talk about what are the future research priorities. Okay, so let me start with the question, why research on newborn health? I'm sure all of us are familiar with the Millennium Development Goals, or MDGs, and we know that the MDG 4 calls for reduction of under 5 mortality by 2/3 between 1990 and 2008. But we also know that most countries are struggling to achieve that goal. The question is why? This chart shows the trends in under 5 mortality and neonatal mortality in the last 5 decades. The upper 2 lines, I think there are 2 different estimates, but very close estimates, shows the trends in under 5 mortality. And as you can see, there has been an impressive decline, although the rates are still high, and high particularly in many countries of sub-Saharan Africa. The lower line is the trends in neonatal mortality, and you can see that while neonatal mortality is declining at a very slow pace, so the stagnating neonatal mortality is the main challenge in my mind that is really kind of making countries, difficult for countries to achieve the MDG 4 goals. So really, I think the current estimate is that about 3.6 million babies die every year in the first month of life. That translates to about 10,000 deaths. Since the neonatal mortality rate stagnated, now neonatal deaths account for 41% of the under 5 deaths. And so I'll say that MDG4 goal can be achieved only if the neonatal health problems are addressed, and which is missing from many programs at this point. And this is a global map showing the distribution of neonatal mortality, and it's not surprising that most of the deaths occur. I think the deep color shaded areas are the areas with highest neonatal mortality. And as I said, it's not surprising that most of the neonatal deaths occur in the resource poor countries of South Asia and Sub-Saharan Africa. 4 countries of South Asia, Bangladesh, India, Nepal, and Pakistan, account for about 40% of the global neonatal deaths. And then this map shows what proportion of the under 5 deaths are neonatal by WHO regions. And as you can see, in all 6 WHO regions, neonatal mortality accounts for a substantial proportion of under 5 deaths. In South Asia, neonatal deaths account for 54% of the under 5 deaths. So this slide is this pie chart that shows the cause structure of under 5 mortality. And as I mentioned, neonatal deaths account for about 41% of the under 5 deaths. And then the bar on your right shows the cause structure of neonatal deaths. And so what you can see that most neonates die from a few potentially preventable causes. 3 causes, birth asphyxia, prematurity, and infection, accounts for about 80% of the neonatal deaths. So, and then this is the slide that shows when most newborn die. And for this, we use data from demographic health surveys of 47 countries. And you can see that up to half of the neonatal deaths occur on the first day of life, and about 3/4 of the neonatal deaths occur in the first week of life. So what is required to prevent these deaths, early deaths? It requires improvements in care during pregnancy, during delivery, and postpartum period. Now let me talk about what is the goal of my research. The goal of my research is to substantially reduce neonatal mortality by conducting 2 things. One is culturally appropriate research to generate evidence, and by supporting effective implementation of the evidence-based interventions. The activities, the research activities I'm engaged can be broadly categorized into 3 types of activities. The first one is, again, develop and test feasible, cost-effective interventions or packages of intervention, including delivery strategies. For that, we use various methods, including formative research, epidemiologic studies, but also we evaluate those studies using very rigorous method. Most of the time, we use cluster randomized trials. The second one is assist with large scale implementation and so that the program performance and effectiveness is improved. And we do that by having built-in monitoring, documentation, and evaluation. And then, of course, use evidence to influence policy and program. Although I really listed them as 1, 2, 3, I think of the influence on policy is not necessarily the last thing we do. As I said, really, we work with program and policy colleagues, and so we try to influence them from the very beginning. And in almost all our research projects, there's a local technical advisory group comprising of colleagues from Ministry of Health, from local academia, research institutions, non-government organizations. They're involved from the beginning of the research, and that's the ongoing activity, and that's a way to increase local ownership of research and way to increase likelihood of adopting the research findings. Okay, so community-based newborn care is a complex intervention. It involves behavior change, involves improving household practices, improving health systems. So by nature, it requires that I work across discipline. And so I really work with colleagues in this room who are social scientists or health economists, for example, because it needs multidisciplinary input. That's what it is. And we together really promote partnership with local and international stakeholders, starting from community to Ministry of Health at the local level, local NGOs, local research institutes, but also international stakeholders or development partners. And so again, I think the purpose is to increase the ownership. We design intervention based on formative research, and my colleague Peter Owen sitting here, he led the formative research bit of many of the work we did. And so, of course, he tried to address major causes of death, and we develop interventions that are feasible, cost-effective, and scalable. Okay, so I came here in 2000, and up to 2007, most of my work was in South Asia, in Bangladesh, India, and Nepal. And in 2008, I thought that I really should work in Africa. The burden of disease is so much high there. So started working in Malawi, and then I have a project now in Ethiopia and Tanzania. If you look at this slide, in every country where we work with the Ministry of Health, even if we are doing a trial, we are developing interventions, testing intervention, we work with Ministry of Health. We work with local research institutes, local and international NGOs, development partners. The research focus in Bangladesh and India, we maintained field sites that allowed us to develop and test interventions. But also we know quite a bit. I think we know what to do. And we know that if we implement the evidence-based intervention, we can reduce mortality by at least half. So there's an increasing emphasis in my work to work with programs and help them to implement those interventions with high coverage and quality. So most of the work in Africa is really work in partnership with programs, and we are using program evaluation that provides feedback to program so that the program strategies are adjusted and then the program performance and effectiveness are improved. Okay, so now let me talk about a project. I think I said that there are two types of work we do primarily. One is generate evidence and then help assist with delivery or implementation at a scale. So the first example is an example of a project that we developed in partnership with a number of Bangladeshi institutions. And this is a project that primarily was developed to generate evidence for interventions. The project's name is Projahnmo, and you may ask what it really means. Projahnmo is an acronym for Project for Advancing Health of Mothers, Newborns and Mothers, but also it's a Bangla word meaning generation. So it is quite known in Bangladesh. It's a partnership of Johns Hopkins University with Ministry of Health, International Center for Diarrheal Disease Research, and a number of Bangladeshi NGOs. Shimantik is an important NGO. They implement many of the research we do. The project started in 2002 with funding from USAID and Saving Newborn Lives. In the last 8-9 years, we conducted a series of studies, and I'll talk about some of them, and we are able to secure additional funding from Gates Foundation and NIH. Briefly, Projahnmo is located, that's a map of Bangladesh, in the northeast corner of Bangladesh. It's in 3 sub-districts of Sylhet district, and with an estimated population of about 600,000. The healthcare utilization and health indicators are quite poor at baseline. The facility delivery rate was only 9%, and skilled attendance at delivery was 13%. Neonatal mortality rate was 50%, and about half of the neonatal deaths are due to infection. We established Projahnmo to design and evaluate effectiveness of a community-based maternal and newborn care intervention package. I'll talk about how we designed the intervention in a minute. We evaluated the intervention using a cluster randomized trial design. We had 24 clusters, each with about 20,000 population, and we randomly allocated them to one of the 2 interventions. We had 2 intervention arms. One is we call home care, and the other we call community care. And so they are allocated to either home care or community care or in the comparison arm. This main outcome was neonatal mortality, but we also measured a number of other outcomes. So this project started in 2002 with formative research to understand local practices and preferences, uh, and also conducted a baseline survey at the end of 2003. And in early 2003, we developed an intervention which is mostly a behavior change intervention and with some level of health system strengthening. Uh, the intervention was designed in a participatory design workshop attended by colleagues from Ministry of Health, NGOs, and local research institutes and academia. The intervention was launched in mid-2003 and implemented for 30 months through end of 2005. The evaluation, we used routine data, but the main evaluation was based on independently collected data. So we conducted a baseline survey and endline survey, but also we conducted periodic sample household surveys, but those are small sample surveys to measure the intervention input processes and more intermediate outcome, whether the practices are changing or not, and those kind of things. So we conducted 3 of them in the beginning of 2004, at the end of 2004, and the latter part of 2005. Okay, so the little bit about the intervention. The intervention components included contact and care during pregnancy. So basically, we made contacts with pregnant women and then promoted behavior change. We also try to improve delivery care and postpartum care and newborn care. The intervention strategies we used included education and counseling, and there's some outreach and facilitation, and there's some level of strengthening of the government health facilities. The primary provider in the home care arm was a community health worker. There's 1 for every 4,000 population, and they provided some selected services at the household level. In the community care arm, the other intervention arm, we didn't have a community health worker, but in both home care and community care arm, we had community mobilizers, 2 types of mobilizers, both male and female, and they promoted the same behaviors, but in a group setting instead of making home visits. Okay, so this chart really shows you how these 3 intervention arms are different: home care, community care, and comparison. Since we had a community health worker in the home care arm, that allowed us to do a number of things, including a 2 monthly pregnancy surveillance to identify all pregnant women. These workers made 2 antenatal home visits and promoted a number of practices like antenatal care, promote antenatal care, tetanus toxoid, danger signs, but also promoted essential newborn care. And the workers also made 3 postnatal home visits, and during those visits they reinforced the essential newborn care practices, but also assessed the newborn using a WHO IMNCI type algorithm. During these visits, the health workers, as I said, they assessed the workers' newborns, and then they managed those newborns. And the management involved, really, the first action was referral. So if there's a baby with a quote-unquote very severe disease, that's the IMCI kind of terminology, but like signs of infection, they're referred. All of them are referred. If the referral was not possible, then the health workers are trained to treat these newborns at home using injectable penicillin and gentamicin. So that was the management. I'll come back to that. In both arms, we had community mobilizers, and as I said, they promoted the same behaviors, but in a group setting. In addition, we trained birth attendants. There are really no skilled birth attendants, so we trained the traditional birth attendants on cleanliness during delivery and danger signs. And then, as I said, we strengthened the government health facilities. So and that also benefited the comparison arm, because the clusters were at a lower level and the health centers are in a higher level, in the sub-district level. So any improvement in service delivery at that level will benefit everybody if they seek care. Okay, so the coverage with the intervention, this is coverage with antenatal and postnatal home visit, and where the antenatal home visit coverage was high. 91% received a visit, 84% received 2 visits, but the coverage with postnatal home visit was not all that high. It's not easy because you have to find a baby within 24 hours and make a visit or third day. And so only 79% received a visit and 41% received all 3 postnatal visits. This is a crowded slide, but it shows that really that the practices improved. And I have just one slide to show that that practices improved, and it is the practice of use of clean cord cutting instrument. And so we have 3 different terms: home care, community care, and comparison, and 4 data points for each of the arm. The first red bar is the baseline, and then the 3 other lines are the adequacy surveys I mentioned. So those are sample surveys conducted every 7-8 months. And so same thing. So home care, you have baseline and 3 adequacy surveys, community care baseline and adequacy surveys, comparison baseline and adequacy surveys. So what you can see that at baseline, that particular practice, prevalence of that particular practice was really less than half, so but very similar. It became almost universal in the home care arm. There was a significant increase in community care arm, but also there was some increase in the comparison arm. And this slide shows the impact of the intervention on neonatal mortality. On your left is the effect on all births. On your right is the effect on singleton babies. And so then the red line is the home care arm, and then the blue line is the community care arm, and the green line is the comparison arm. So what you can see is really there was a rapid decline of neonatal mortality in the home care arm, and we don't see that in the community care arm. And if we look at the effect size, there's a 34% reduction in the of neonatal mortality in the home care arm, and there's no reduction in the community care arm. If we restrict the analysis to singleton, of course, there's a higher impact, 46% reduction. Okay, so in the home care arm, we had a community health worker, and we collected more detailed data, and that allowed us to address 2 additional questions. The first question is, what is the effect of community case management of newborn infection? And the second question is, what is the effect of timing of first postnatal home visit on neonatal mortality? And so the data we used, as I said, is the home care data. So it's not anymore the trial data. This is more observational data from one arm of the study. And we are able to address these questions because there are variation in intervention uptake. So there are about 10,000 plus live births in 2 years in the home care arm. About 20% of those babies are preterm, about 30% of them are low birth weight. 79% received at least one postnatal home visit from the health worker, and these community health workers collected data on timing of visit. As I mentioned, they used the IMNCI algorithm to assess newborns, and they recorded signs of morbidity and management and outcome. So about 7% of the neonates had signs of infection, meaning that they had an indication for antibiotic therapy. As I mentioned earlier, the first action was referral. So the community health workers referred all these babies, but only 34% of the families were able to take their newborn to a health facility. So if referral was not possible, the health workers requested parents' consent to treat the baby at home using injectable penicillin and gentamicin. 43% consented, and the 23% of the households, they neither were able to comply with the referral or they didn't consent to home treatment. So there are 3 different groups. One group went to the health facility, one group treated by community health worker, and there's a group either didn't receive any care or received care from an untrained local provider. The case fatality rates, which is not in the slide, were about 4.4% with community health worker treatment, 14% with facility care, and about 30% with untrained care or no care. Of course, there are issues of selectivity because this is not really randomized trial data. This is observational data. So we try to adjust for some of the differences in background characteristics and illness severity, and estimated that the proportion of sick babies who died was 40% lower in a facility care and 78% lower with CSW care. The comparison is untrained care or no care. So based on that, we concluded that CSW treatment was acceptable, safe and effective, acceptable with some there's some problem with that because we saw that 1 out of 4 households didn't consent to CSW treatment. So it's not a universal acceptance. There's an issue of acceptance there. Okay, so the second question was the impact of timing of first postnatal home visit on neonatal mortality. The program goal was to make 3 postnatal home visits. I mentioned that on day 1, 3, and 7. But you also saw that only 79% received a visit. So 21% of the newborns did not receive any postnatal home visit. And also, I think, again, about a third received a visit on the first day, and another third received a visit on the second day, and so on. So what we have found that really a postnatal home visit from a trained health worker on the first day or second day were associated with about 2/3 lower mortality. And after that, there was no effect, mainly because deaths are so much clustered in the beginning of the life, so first and second day. So based on that, we basically concluded that a early postnatal home visit with appropriate content and quality is critical for newborn survival. Okay, so what happened? The trial ended, and then what happened after that? After that, the Ministry of Health, Government of Bangladesh developed a national neonatal health strategy. That's a piece of document. It's not much meaningful if it's not implemented. So USAID Bangladesh supported the trial, and then they supported, I think, Access or MCHIP. That's their program project, global program project, to implement the intervention in 2 districts. UNICEF Bangladesh supported implementation of the intervention in additional 6 districts. And finally, based on our work, but also work of their other studies in the region in India and Pakistan, UNICEF WHO issued a joint statement in 2009 with a title that Home Visit for the Newborn Child, a Strategy for Improved Survival. So the WHO UNICEF joint statement recommended at least 2 home visits on day 1 and 3, and if possible a third visit on day 7. It's important to recognize that home visit itself is not intervention. It's a delivery platform. It's a delivery strategy. And it's important to have evidence-based intervention delivered in that visits with high quality. So WHO recommended that that health workers should promote essential newborn care, which is breastfeeding, thermal care, hygienic cord care, but also promote recognition of danger sign, care seeking, and so on. Okay, so what we have done after that in that particular trial area, which established a trial site, and so what we have done after that, we have been quite busy. I think we've just finished a trial, another cluster randomized trial, and 32,000 babies between 2006 and 2009. And so that was to evaluate the impact of chlorhexidine cleansing of umbilical cord on neonatal mortality. We have 2 ongoing studies. One we call a healthy fertility study, and that is an attempt to integrate postpartum family planning with maternal and newborn care package. We have a study on safety and efficacy of simplified antibiotic regimen for outpatient treatment of infection. That really, the genesis of that study is our observation that although community health workers in the Projahnmo 1 were able to treat sick newborn successfully, there are concerns about the feasibility of large-scale implementation. I think you have to train health workers to give 2 injections for 7 days, which is not so easy. But also there are issues of community acceptance. We saw that about 1/4 of the households didn't accept CSW treatment. so we are doing a trial to develop a comparing two simplified antibiotic regimen with the standard, and that study is now ongoing. We are about to start two more studies. One is the etiology of newborn infection. That's a Gates-funded study. It's a 3-country study in South Asia, Bangladesh, in Pakistan, and India. And so our site is the Bangladesh site, and that study will be starting in a month or so. And then also we'll be starting a study in another 2 months, which is basically an evaluation of a screen and treat program for maternal infection. And it's really two specific infections, bacterial vaginosis and urinary tract infection. And there's some indication that this will reduce preterm birth. I think the literature is, of course, conflicting. So what we'll be doing is using a cluster randomized design. In half of the area, mothers will receive the maternal newborn care, standard maternal newborn care. In another half, they'll get maternal newborn care, but also a screen and treat program. So they'll be screened and for bacterial vaginosis and UTI, and if they're positive, they'll be treated early in pregnancy between 16 and 19 weeks. And we hypothesize that that will reduce neonatal preterm birth rate by about half. But there are other outcomes of that study, including stillbirth and early onset sepsis. Okay, so I'll just talk briefly about the chlorhexidine trial. And so WHO recommends dry cord care, meaning apply nothing to the umbilical cord. Then the question is then why we evaluated a antiseptic and its effect on neonatal mortality. We know that the WHO recommendation is based largely on facility data, and that recommendation may not be relevant for countries where most deliveries take place at home in unclean environment. And so chlorhexidine is a broader spectrum antibiotic, and that's widely used. And in fact, the first study of chlorhexidine called cord cleansing was conducted by colleagues sitting in this room, Luke Mulani, Jim Tilch, and others in Nepal. And so they tried multiple cleansing and showed a 24% reduction in neonatal mortality. So ours was the second study in a way to confirm or refute the Nepal finding, whatever it is. But there are some differences between the Bangladesh and Nepal study. What we did is really we developed the maternal newborn care package as part of the first study, and so we implemented that maternal newborn care package in the entire trial area. A trial area served by 133 community health workers. And then we randomized these health work areas into two types of chlorhexidine intervention. One is a single cleansing, there is 7-day cleansing, and of course there's a comparison arm that is dry cord care. The sample size was about 32,000. We came up with a mixed result, which is I think so. What we have seen is really the single cleansing reduced neonatal mortality by 20%, but the multiple cleansing that showed a 24% reduction in Nepal didn't show a significant reduction in Bangladesh. So there's a third trial just completed a year ago in Pakistan, which also used multiple cleansing and showed a 39% reduction in neonatal mortality. So what we did is really we had a meeting of investigators from all 3 sites last year, and then we looked at all the data and did a meta-analysis and found out that any chlorhexidine application was associated with a 20% reduction of neonatal mortality. I cannot say too much because the Bangladesh and Pakistan results are not yet published. Of course, the meta-analysis is not published. But I think there's indication that chlorhexidine cleansing is safe, low cost, and can save lives. Okay, so let me now move on to the second stream of work I do, the program evaluation to improve program effectiveness. And so what we did is really we conducted a large evaluation of a large program in India, and the program is known as Rachna. It's a program implemented by Care India with Government of India. And so Rachna is a large program. It's a large program, means it covered about 100 million people in 8 states of India. So it was an integrated program that addressed maternal health, child health, including newborn health, family planning, and RTI, STI, HIV, and so on. It was a facilitation program, in the meaning that Care India did not really implement the intervention. The implementation was through the two existing programs. And those of you who know India, the programs are Integrated Child Development Services and Ministry of Health. So what was CARE's input? CARE's input was more in the planning, designing, training, coordination, monitoring, and all of those. So CARE provided assistance in the implementation, but the actual implementation was with the existing program. So what we did is really we evaluated the newborn component of that program, and the newborn package was similar to the Projahnmo package we evaluated in Bangladesh, with the difference that there was no community case management. So the other interventions are very similar. We used a quasi-experimental design, so we conducted a baseline survey and an end-line survey, of course, but also we conducted interim assessment, both quantitative and qualitative. So like Bangladesh, we conducted adequacy surveys so that there is feedback. And so we conducted these interim assessments, provided feedback to the implementers so that the program strategies can be adjusted as needed. So this is some results. This is the coverage with antenatal and postnatal home visits, and the top 2 lines, the blue and red, are coverage with antenatal home visits by a community worker. And as you can see, I think so at baseline it was around 20% in both areas. It increased to more than 60% in the intervention arm, but really there was no increase in the comparison arm. The bottom 2 lines show coverage with postnatal home visit, and it was really like only 2% of the mother babies are getting a postnatal home visit in that population. It increased some in that yellow line is the intervention, some in the intervention arm. It's really, in a way, it's a lot, from 2 to 26%. That's a 13-fold increase, but still the coverage was 1 out of 4 babies are getting a visit, and there was no change in the comparison arm. There's some improvement in practices, and I just chose one behavior, that is initiation of breastfeeding within 1 hour, and you can see at baseline that practice was about 2 to 3%. There's a slight increase in comparison and quite a bit increase in intervention, but still it remained low. Okay, so we measured mortality and did not observe a reduction in neonatal mortality. And then we asked ourselves why. Of course, we didn't see a reduction in mortality because the coverage remained low. There's some increase in coverage and some improvements in practices, but not sufficient to show a mortality impact. But then we looked at that subset who received the intervention, those who received the postnatal home visit within 3 days, and we saw that they really benefited. There was a significant reduction of mortality. And then we tried to model the data. We modeled the data to measure what would have been the impact if the coverage was, say, 70%, 80%, 90%, or so on. And so that's not data, that's modeling of the data. And at 90% coverage level, there would have been about 30% reduction of neonatal mortality. So it says that the technical interventions are really sound. It's the problem of achieving coverage and sustaining quality in large programs. That's the challenge. But also, like, I personally think that it's not, most programs really look at processes, and that's not probably sufficient. It's really important to also pay attention to results. Okay, so let me move on. And so we just are starting a project in Tanzania, which is again a program evaluation with partnership, in partnership with Ministry of Health and Social Welfare and DrPH, which is a Hopkins affiliate here. So DrPH is working with Ministry of Health. They developed a maternal child health program, and what we are trying to do is really develop a intervention, evaluation, and to improve access, coverage, quality, and continuity of MNCH intervention. How do you want to do that? I think we basically, again, are developing built-in assessments that, and so that will generate feedback to the program implementers, and then we plan to adjust the implementation strategies every year with the hope that we'll have a program that will be effective. And of course, then we want to evaluate the effectiveness and cost of the final intervention package. Okay, so in this last part of my talk, let me briefly talk about what I think those of us are working on newborn health should focus on the next 5 to 10 years. Of course, we should continue to research newborn health, both to generate new evidence and to assist with translation of evidence-based intervention. So that's the two-track research strategy: develop evidence and assist with implementation. The newborn health research agenda is still not really complete. We need to learn how to prevent preterm births or manage complications of preterm birth. The study we are trying to do, I briefly talked about the study of a screen and treat program during pregnancy has preterm birth as the main outcome. So that's one effort to reduce the burden of preterm birth. But also, I think in that study have other outcomes like stillbirth and early onset newborn sepsis. So what I'm saying is really, I think the newborn research agenda is not complete. We need to continue to focus on that. But also, I think we need to broaden our scope to more systematically address maternal health issues and stillbirth. I say that because we know that the maternal health and perinatal health, which includes stillbirth and newborn health, are intimately linked. They are very, very much linked. And so that's more like the development part of it, develop new intervention. But also I think, as I said, I think I suggest that we maintain the two-track research strategy, develop and deliver. I'll come back to that. Okay, so this is more an illustrative figure. It's not real, but it shows that the risk of death is highest in mothers and fetus and newborn around childbirth. So there should be an opportunity to develop interventions against all of them and then deliver them as a package. A little bit about the maternal health. I think it's all known that about 400,000 mothers die every year globally from complications of pregnancy. The rates are highest in sub-Saharan Africa. It's about 600 per 100,000, but there are countries in sub-Saharan Africa with a rate of 900 or even 1,200. And then the second highest rates are in South Asia. Most deaths occur during childbirth and the first week postpartum. Few conditions, postpartum hemorrhage, infection, eclampsia, and obstructed liver account for 80% of the deaths. The death is only part of the story, but also about 10 to 20 million women develop physical and mental disabilities every year as a result of pregnancy and delivery complications or poor management of complications. There's a number of Lancet series, and there's a Lancet maternal health series that argued that health center intrapartum care strategy is the best bet. I'm not contradicting that. I think I agree with that. I think the facility-based strategy is probably the best bet. The problem is really it's not going to happen in many countries in the short run because it requires long-term investment in health systems. The question is what can be done in the meantime? From our experience of community-based newborn health research, we feel that there are opportunities to develop interventions, community-based interventions to prevent and treat maternal maternal health problems. This is a partial list of maternal interventions. The first three of them, antenatal care, tetanus toxoid, skilled attendance at delivery, are part of almost any program. The problem is the coverage. The coverage is low. There are other interventions like misoprostol for postpartum hemorrhage, calcium for prevention of eclampsia, magnesium sulfate for severe preeclampsia and eclampsia, and antibiotic for sepsis. All of them have potential to be delivered in the community, but there will be additional both developmental and work will be needed, and also delivery strategies will have to be developed. So I was just looking at this paper by Christina Pagel et al. Or her colleagues. They did a modeling exercise. It's not data. And so they really modeled the estimated effect of three packages of intervention for sub-Saharan Africa. The first is a health facility strategy. Second is the health facility strategy plus distribution of misoprostol for PPH and antibiotic for infection antenatally through community health workers. And third strategy is first and second strategy plus distribution of drug through community volunteers. And then they estimated that the health facility strategy has the potential to reduce maternal mortality by 12%. The second strategy that also involves distribution of misoprostol and antibiotic through community health workers has the potential to reduce mortality by 24%. And the third strategy has the potential to reduce by 32%. This is modeling, and there is no empiric data. So what I think is really trials are needed to determine the safety, the issues of safety also of misoprostol distribution, feasibility and effectiveness, as well as cost of these and other packages of maternal interventions. The stillbirth, there are 3 million of them per year, and most of them, 99% of them, occur in low and middle income countries. Despite large burden, stillbirth is not currently included in MDG tracking, of course. Stillbirth rates may improve with intervention directed towards women before and during pregnancy. So we may have the opportunity to deliver this intervention coupled with intervention for newborn and maternal health. There are many suggested interventions. There are a couple of systematic reviews looked at interventions that has the potential to reduce stillbirth. The problem is the evidence for most of those interventions are either lacking or low quality. So this is again a partial list of stillbirth interventions, and that can be delivered before pregnancy, during pregnancy, and during interpartum period. And you can ask me how I picked them. Maybe they are my personal favorites. I just picked them because I thought that some of them are in the program, like intermittent prophylactic treatment for during pregnancy for malaria, or ITN distribution, and they have quite a bit impact. So birth preparedness is part of some programs and has quite a bit impact. So basically there are interventions that can be delivered. The two interventions, screening for asymptomatic bacteriuria and bacterial vaginosis, I included them because we're studying that now. And so there are interventions that can be packaged with maternal interventions and newborn interventions and can be delivered. And so there are opportunities to combine all of them. Let me leave you with some concluding thoughts. The program, I think I try to make the point that the problems of maternal and newborn mortality and morbidity and stillbirths are closely linked and account for a large burden of poor health outcomes. I suggested that we continue our research focus on newborn health, but broaden our focus to encompass research to improve maternal health and reduce stillbirth. There's a need to develop additional intervention, including community-based approaches to reduce the burden of preterm birth, stillbirth, and maternal mortality. We do have evidence-based intervention with the potential to reduce newborn and maternal mortality by at least half or more, like in fact 2/3. The question is how to deliver them. I agree that really universal coverage with skilled attendance at delivery and facility-based care is the way to go. But the problem is it's going to take time, and there's sufficient evidence that community-based approaches can expand access and improve survival in resource-poor setting. Finally, I again think that we need to maintain this two-track research strategy that is develop and deliver, develop and test new innovative interventions, particularly for preterm birth and stillbirth, and assist programs to successfully implement those interventions at a scale. Thank you.
Mics. We should use these mics since we're taping this for people who couldn't be here. But let me ask the first question. So there are a number of large trials of micronutrients and other interventions in pregnant women in Bangladesh and other countries. Is there any thought of layering the intervention for newborn care on one of those other trials, so you have a factorial design and you can test whether there's added benefit?
Sure, Kate West and I talked about that. I think there are opportunities of doing that, and so there are two large field sites. Hopkins has in Bangladesh. You visited on the Jibita, great project, and then the Projahnmo is the other side, and we are trying to work together, and not just trying to work together, but I think there is a opportunity to layer interventions, more like health systems type of intervention, but also more biomedical interventions like micronutrients. Yes.
Thank you.
Yeah.
So any comments or questions for Abdullah?
Abdullah, that's a great talk, as expected. Let me talk to you a little bit about the India evaluation, and especially the modeling exercise, trying to understand whether or not coverage, in fact, was associated. I think almost everybody agrees that for most public health interventions, especially in poor countries, that the folks who receive, maybe the first 50% of the folks that receive the interventions probably didn't need it anyway, right? And that all the action is really in those that are hardest to reach, and that's where the risk is. That's where most of these interventions actually make a real impact. So I'm interested to hear your reaction to trying to evaluate the 25% coverage of those who got a postnatal visit in the first day, and noticing that their mortality was about 25% lower, or something like that, or whatever the reduction was. Do you think that actually had to do with that postnatal visit, or is that the group that was at much lower risk to begin with, and that you really don't expect to see the benefits for the postnatal visit, except in those people who didn't get much coverage?
That's a great question. I think that's the problem with any analysis that's beyond randomized design or even quasi-experiment. I think when you deal with observational data, I think there are problems. And so, right, so it's possible that really those who received the visit, I think there could be a reduction in mortality, even in absence of that. Or it could be, I think, in fact, in our modeling, we try to take into account some of those differentials, I think, but I think to the extent you can. And so, of course, those who received the visit and those who didn't are not same, they're different. And we try to adjust for that or standardize for that to the extent we can. And so it's possible that really some of those decline could be without that visit. But also it may suggest that really if the coverage could be expanded, and if we could reach more like hard to reach population, there could be even a higher effect. So both are possible. And so that's true. I think that question, Jim, that is true also with the other analysis, the Bangladesh data, like the effect of postnatal home visit, because that's observational data, and of course it's not randomized trials. Unfortunately, that is all we had. So
Any other comments or questions? If not, we're going to have a reception outside where we can talk one-on-one with Abdullah, and I want to thank you for giving a great talk and an impressive body of work. So.